Good evening, everybody. Welcome to the H&D webinar. My name is Greg Hallstrom. I, along with my business partner, Rob DeLillo, and also my brother-in-law, founded H&D almost a quarter of a century ago. Sometimes it feels like a century ago, and other times it feels like yesterday. But during that time, we've shared the many ups and downs of New York City. And from 9/11 and that rebuilding, to the stock market crashes and record breakers, and then crimes and homelessness going up and then down, then up, and now the COVID epidemic. But we New Yorkers, we keep making it through, and it's because of you, and it's because of us together, the power of this community. It's what makes us New York City strong, and we're looking forward to these city lights shine again. And so these monthly webinars have been an opportunity for us to stay connected with you, our H&D community. And within the topics of these webinars, there are communities within themselves. I'm assuming all of you here tonight are here because you're avid tennis players and you're anxious to get back on the courts as the weather warms up. I'm also going to assume you're here tonight because you don't want to get hurt. You want to learn some exercises to keep you strong and limber for the upcoming tennis season. And you know, you're in the right place because we have two great presenters here for you tonight. But before I introduce them to you, I just want to go over one thing, one rule or baseline thing that we do here at H&D, and that we take a systems approach to our rehab and not a symptom approach. So what that means is, if your elbow is hurting, if you have that tennis elbow, it may not necessarily be the elbow's fault. And let me describe that. Let's just have you all who's on the call right now, just stand up for a quick second, and I'll explain to you what that means. So if you stand up, and if you just take both hands and just rotate as far as you can one direction, and then twist the other direction as much as you can. Okay, how did that feel? Now I want you to do the exact same thing, but this time keep the arches of your feet flat on the floor. Just keep them pressed down, and with those arches down, keep the pressure on there. As you turn as much as you can, and turn as much as you can the other way. And chances are it felt different that time. I felt it in my back, and it's not necessarily was because my back's fault. It's because the foot and ankle didn't do their job. And so somewhere else up the body and up the chain had to work harder than it needed to. So that's the H&D systems approach to things, because we're not just looking at where it hurts, but why it hurts and where it's coming from. So let me introduce you to one of H&D's best systems approach physical therapists for tennis, and that's Aaron Huppert. Aaron here is a physical therapist at our Upper East Side clinic and has over 20 years experience with a primary focus on sports medicine and rehabilitation. Aaron also serves as H&D's physician liaison, building communication and trust with over the 1,000 physicians that refer to us. He completed his undergrad work at University of Michigan, 4 Sweet 16s in a row, and actually my pick to win this year, and his master's degree in PT from New York Medical College. He is a certified McKenzie clinician and has been recognized by the Hospitals for Special Surgery as an advanced hip clinician. Aaron is an avid tennis player, and when he's not recovering from injuries, he's a member of the Westchester Tennis Men's 4.0 USTA tennis team. And also that we have tonight is Dr. Alexis Colvin, who's a professor of orthopedic surgery and associate dean for alumni affairs at Mount Sinai. A graduate of Princeton University, she received her medical degree from Mount Sinai and completed her orthopedic surgery residency at NYU Hospital for Joint Diseases. During her residency, Dr. Colvin was selected for one of the most prestigious sports medicine fellowships in the country at the University of Pittsburgh Medical Center. That's true. Some of the best physical therapists come out of UPMC as well. And while in Pittsburgh, Dr. Colvin cared for professional athletes, including the Pittsburgh Steelers and Penguins, collegiate athletes at the University of Pittsburgh, and numerous other collegiate and high school athletes. Dr. Colvin specializes in the surgical treatment of the knee, shoulder, and hip disorders, She has authored numerous scientific publications and has presented both at national and international meetings on sports medicine and orthopedic surgery. Dr. Colvin is a board-certified orthopedic surgeon and member of the American Academy of Orthopedic Surgeons, the American Orthopedic Society for Sports Medicine, Arthroscopy Association of North America, and International Society for Hip Arthroscopy. Dr. Colvin is the Chief Medical Officer for the US Open, the team physician for the US Fed Cup team, and previously served as Chief Medical Officer for the United States Tennis Association. Dr. Colvin has also served as a physician at the US Olympic Training Center in Colorado Springs. Crain's New York Business recognized her on their inaugural Notable Women in the Business of Sports list in 2019 and has been selected as a New York Magazine Top Doctor yearly since 2016. So it's a real privilege and an honor for all of you to have joined us tonight, and a privilege to have Dr. Colvin and Aaron Huppert here tonight. So thank you all for making the time, and we're going to get started with Dr. Colvin's presentation. Thanks again. If you have any questions along the way, please don't hesitate to just tap on the Q&A button and chat your questions in. Thank you very much.
Thanks for having me. So I'm going to share my screen now. So before I get started, I actually just wanted to commend those of you who most likely play tennis. And if you do, in particular, if you play through the USTA leagues, there was actually a study that I did a few years ago where we actually had over 10,000 leagues players respond. So thank you if you're one of the respondents. And what we found was that the USTA recreational tennis playing population is much healthier than the general population when we measure it by actual objective metrics. And so what kind of metrics are these? So there's something called the SF36, which actually looks at a number of different domains, including both physical and mental and social health. And it's a standardized score that's been around for years. It's used a lot in healthcare with other conditions such as diabetes or heart disease. And it's also been used to look at the general health of NC2A athletes, but it's never been done before with recreational tennis players. So it's probably one of the largest studies of its kind. And so if you look at the statistics here, the average BMI of the league's players is within the normal range, so very healthy population. But if you look at the last point, I would say this is probably the most important point to me, that on every single variable measuring both physical, mental, and emotional health, tennis players actually scored better than the general population, which is pretty incredible. We did find some trends in that the younger athletes and those who played, and again, you're all athletes, and those who played tennis more than 3 times a week tended to do better. And then the higher your ranking also correlated with it with a better score. So I would just say, congratulations for being part of such a healthy group. So how are we going to keep you that way? So I'm going to go through, I would say, the most common injuries that I see. And like Greg mentioned, I serve as the team physician for the US Fed Cup team, now renamed for Billie Jean King team, and then also at the US Open. So I see a number of these injuries, and hopefully I will keep you from having these be a part of your tennis playing life. So I usually like to start with the anatomy so you can get an understanding of what exactly we're talking about. So starting with the shoulder, can you see my pointer here? The shoulder is actually 2 sets of bones. So you have the collarbone and where it meets the scapula, the wing bone, and then it's also where the scapula here meets the humeral head, so the top part of your arm bone. And it actually is the most mobile joint in the body. So what do I mean by that? So if you look at the hip versus the shoulder, they're both ball and socket joints. But the socket for the shoulder only covers the ball part of the shoulder about 1/3, versus in the hip, the socket covers the ball part almost 75%. So that not only means that you can move the shoulder in a lot more different directions, it also means that the shoulder potentially takes less force for an injury to happen. If we look at the muscles and tendons around the shoulder, as I'm sure all of you are familiar with, the rotator cuff. And so here's a picture on the right of the front muscles of the rotator cuff. And so when you look at this picture, The red part is the muscle and the white part is the tendon. If you injure the muscle, it's red because the blood supply is really good to it. And so a muscle injury will heal on its own. If you have a tendon injury, this connection, the actual connection to the bone, the reason this is a problem is because there's not good blood supply to it. And so that's something that potentially will not heal without surgery. And then this is the back of the shoulder here, just showing the rotator cuff muscles on the back. Then if we go one layer deeper into the shoulder, so this is looking at the front of the shoulder, this is one of the rotator cuff muscles here. And then if we peel away the muscle in the front, there's something called the shoulder labrum, which lines the socket of the shoulder. And so that's something also that occasionally can be torn in overhead athletes such as yourself. So when we talk about tennis, probably the motion that is most likely going to cause pain in somebody who has a rotator cuff injury is the serving motion or an overhead hand motion. And so you can break the tennis service motion down into these different phases, but the point I want to drive home here is that it's a very common issue in in tennis players. Almost 50% of tennis players will have shoulder pain at some point. It typically is an overuse phenomenon. So it's just the repetition of going overhand, although there can be multiple etiologies for it. There's this concept of the kinetic chain where the shoulder is really the funnel for the force coming from your core to deliver the power to your racket to hit a ball. And so when, and I'm sure Aaron will talk about this, when you are having a shoulder problem, you don't want to look at it as just a shoulder problem. You want to look down the chain as well to see, is there something in the core that's causing the problem to then manifest in the shoulder? So at what point when you have shoulder pain do you want to see a doctor? Well, for sure, number one, if there's been some sort of trauma, like a fall or something very obvious, what caused the injury, that I would say you probably want to see a physician first. If there's weakness, for instance, if your power just doesn't feel like you have that anymore. If there's swelling around the shoulder, which is usually a little less common, it's usually more in other joints. If there's any bruising, because that can also indicate that something is torn. If there's numbness and tingling, because that may not actually be the shoulder, it could be nerve related. If there's a change in the appearance of the muscles. So if you look at this picture, if you look at the picture on the right, that's a normal biceps contour. And if you look at the picture on the left, that's someone who has something called a Popeye deformity. And so what's happened there is that the tendon for one of their biceps muscles actually torn and then slipped away from where it's supposed to be. And that gives you a very distinct change in the appearance of the muscles. And then if you've really had no relief or taking over-the-counter Advil or Aleve, that's when you may want to go see a doctor sooner rather than later. When you go to the doctor, there's usually a series of imaging that will happen, including x-rays to see if there's any bony issues, ultrasound, which can be done in the office for certain pathologies, but not everything. And then at some point, you may wind up getting an MRI or something called an MRI arthrogram, which is a study where there's actually dye injected into the shoulder first before the MRI is done. And there's certain reasons why you would do the dye study, because sometimes there's some findings that are a little more subtle that won't get picked up on a regular MRI. And then with treatment, again, I'll leave this more to Aaron, but one thing to keep in mind is that there's actually 17 muscles that really are considered part of the shoulder muscles. So even though you may think you're working on strengthening your shoulder muscles, a lot of times you aren't getting those really small muscles that are often ignored. And that's where establishing a good regimen is helpful to make sure you have a complete shoulder program. So the next thing we're going to talk about is tennis elbow. So obviously this is a very common tennis issue. And so if you look at what the actual problem is, here's a side view of the shoulder. Actually, both of these are. And so there's muscles on the side of your, on this side of your arm, which are called the extensor muscles. And they're the ones that help to move your wrist up like that. So to extend your wrist. But they actually, even though they connect at the wrist, they actually attach all the way up at the elbow. And so when you have tennis elbow, it's usually a motion that's exacerbated by the wrist, but you feel it up at the elbow. And so The actual pathology actually is not necessarily tendinitis, but more of something that we call tendinopathy, where the tendon itself, if you were going to take a microscope and look at it, actually shows micro tears within it. So in addition to physical therapy, some of the other treatments that we will try include something called a counterforce brace, where if you look at the picture down here, it's a brace that's actually worn below the elbow. Occasionally injections, anti-inflammatories, and then this last thing I really would stress that you look at too, which is the equipment, which is obviously your racket. So in terms of grip size, head diameter, stringing, those are all really important things to look at if you're suffering from tennis elbow and shoulder problems. And then finally, I'm just going to talk about the knee. So if we look at the knee from the front, so this would be with the head at the top and then the kneecap here and the foot at the bottom, there's a number of big muscle groups that go across the knee. So you have your quadriceps muscle, and quad means four. So there's four different muscles that then attach to this thing called a tendon above the kneecap and also below the kneecap. And so one of the most common chronic problems that can happen in tennis players is something called patellar tendinitis. We sometimes refer to it as jumper's knee because we also see it in athletes that do sports that require a lot of jumping, such as basketball and volleyball. But I definitely see it in a fair number of my tennis players as well. And so the hallmark, if you look at this picture here, is that it actually is tenderness below the kneecap over the patellar tendon. And it's very, very classic to diagnose because you just have to put your thumb below your kneecap, and that's really where the problem is. You don't usually need an MRI for this, but it is something that typically can be helped with physical therapy. There's a lot of different philosophies in terms of what type of physical therapy can help with it. This is, I would say, the for a while considered the gold standard rehab, the eccentric quadriceps strengthening, where you're actually contracting the muscle and elongating it at the same time. But there's a lot of different thoughts on are there other ways to rehab it as well. Some people also find that wearing a patellar tendon strap, so that strap right below the patella, can be helpful, as well as anti-inflammatories. And then if we go a little deeper into the bony anatomy, what I want to show you here is that there's actually three sections to the knee. So you have the thigh bone and the shin bone and the kneecap, and then we divide that up into the inner compartment of the knee, the medial compartment, the lateral compartment. And here's a side view, and this is the patella and the femoral compartment. So the meniscus is probably one of the more common knee pathologies that can happen from a tennis. So if you look at this picture here, this is a top-down view. This would be one meniscus on the inner side called the medial meniscus, and then this is the lateral meniscus on the outer side. And so if you look at this picture here, the reason there's this different color scheme is that the best blood supply to the meniscus comes from the outer part of it, and as you go in, there's less blood supply there. And so that can be important when you have a meniscus tear, because there are certain meniscus tears that actually can be repaired, sewn together, and then other meniscus tears, which are in the area with not good blood supply, that may wind up needing to be trimmed out. And then there are also a number of ligaments around the knee. This is a front view here. So you have the ACL and the PCL. And I would say they're more common in cutting and pivoting sports like basketball, soccer, skiing. And then the MCL and the LCL, the two ligaments on the sides of the knees that are also a little less common to get injured with tennis. So with the meniscus, the reason it's important is because it actually has a number of different functions with absorbing shock in the knee. In particular, if you look at this picture here, you have these little, the meniscus are two pads on either side of the knee, and what they're cushioning is something called cartilage, which is the surface that gets worn down with arthritis. So if a meniscus is torn, the natural history of what happens down the line is that that person can potentially develop arthritis because that cushion is not as good as the one they were born with. So here's just another picture. When I say torn meniscus, what happens is you can have a lot of different configurations. So if you look at this one here, this one, the normal contour would be all the way here, and the tear is extended this way. And so this is almost like a flap called a bucket handle that can tear. And then you can also have a tear like this one where it actually goes sort of perpendicular to the meniscus there. So in terms of when to see a specialist, to see a physician, again, pretty similar to the ones for the shoulder. So if there's trauma, such as a fall, if you have difficulty bearing weight, if your pain gets worse with daily activity. So maybe you only notice it on the tennis court, but then if you're noticing it even with daily things like stairs or squatting down to get something out of a low cabinet, that may be something where you want to see a doctor sooner rather than later. And then also if you really had no improvement with rest or over-the-counter NSAIDs. So this is actually, even though I'm the team physician for the Fed Cup, I actually have traveled with the Davis Cup team before. So just to mix up the genders here a little bit. Thanks.
Thank you, Dr. Colvin. One question came in, and regarding when there's a labral tear in the shoulder and when tightening up the capsule post-operatively, how do you, knowing that tennis overhead, to gauge if to make it too tight, I guess, concern about restricting the range of motion after surgery?
Yeah, that's a good question. There's a lot of different types of labral tears. So if you have it in the top part of the labrum, that's called a slap tear. So it's the superior labrum. And then if you have a tear due to instability, that's a different beast altogether. So I think it really depends on what the underlying problem is. If it's instability, then yes, you will have some tightening because you are trying to restrict motion. If it's a slap tear, sometimes there's technically you can put your anchors in a slightly different part so that you don't restrict people as much overhead. But I would say it's a much debated surgery in any case for an overhead athlete.
Okay, great. Thank you. Also, you mentioned injections for the elbow. What types of injections were those? Cortisone?
For tennis elbow?
For tennis elbow.
I would say there's a number of different treatments that have been described. So cortisone, but the downsides of cortisone are that, if you have cortisone in the tendon, it could potentially cause it to tear further, although it is very good for pain relief. There's also something called PRP, which stands for platelet-rich plasma. And so the idea behind that is that it's more of using your own biology to potentially try to help with the tennis elbow. But I would say it's a little controversial in terms of how many doses of PRP do you need, what's the concentration. So I would say those are certainly options. The main thing is that it's a tendon, so it's not something that heals on its own. Even though you may feel better with physical therapy, again, if you get an MRI and it shows that you have breakdown of the tendon, that will not change structurally because that's just what your tendon has become. And so when you do those injections, sometimes what we do is try to do almost like a little needling of the tendon, try to get it to bleed, and so that your body can try to do a little bit of repair.
Very interesting. Thank you. What is the best method for preventing treating groin pulls and injuries? And this may be directed towards Aaron as well.
Yeah, I guess, I'll let Aaron answer, but I would say, the groin is really part of the core. And so I think definitely, I would say if you're going to have one specific area to focus on, it would definitely be the core, because that's going to affect not only groin strains, but also everything up that kinetic chain I was talking about. So shoulder, elbow, wrist issues. So, but I'll let Aaron speak more about how to prevent that.
Okay. And how about the hip? Can the hip, what types of injuries do you see the hip, and what kind of rehabilitation or common injuries?
So other than the muscular ones, like the adductor groin strains, I would say hip labral tears are probably the, similar to the shoulder. There's also a labrum in the hip. And we tend to see that with sports which require rotation of the hips. And obviously there's a number of notable tennis players who've had hip issues as well. So that one, again, I think kind of goes back to core strengthening as a preventative measure.
Okay. And final question, are you seeing new patients?
Yes, definitely. Yeah. I would say Mount Sinai was I would say definitely one of the epicenters of treating COVID patients, myself included. Even though I'm an orthopedic surgeon, I took time off of my practice and went to serve on the floors. And so I think we all feel very comfortable with all the protocols. And obviously, there's increased use of vaccines. So I think in terms of people who are concerned about coming into the hospital, I would say it's probably one of the safest places to be, just because there's so many precautions are being taken.
That's great. Thank you very much. Actually, I do have one more question for myself. You had mentioned earlier too with the non-contact sport of tennis. I imagine many injuries are insidious onset or gradual onset versus acute strain. And would you mind just going over the difference between tendinosis versus tendinitis, maybe with the
yeah. So I guess the first point that you were talking about in terms of the type of sport. So we can divide sports into contact and non-contact sports, and even with the contact sports, those that are really collision sports like hockey, football, where people are really actually physically colliding with each other, versus tennis, which is most of the injuries happen from overuse. So there's not a lot of trauma because there's not much contact. So I would say I wouldn't really differentiate between tendinosis and tendinitis as separate things that happen with someone who uses too much of the as an overuse injury, because they're sort of along the same spectrum. So I would do tendinitis, tendinosis, and then tearing. So when you have a tendon, if it's just inflammation, that would be tendinitis. If you have a tendon tear, that's obvious, it's torn off where it's supposed to be. But tendinosis is sort of this middle ground where the tendon, is still attached to where it's supposed to be, but again, you have these micro tears in the tendon. And so you could have certain tears in the body, you can have micro tears, and you know that if it stays that way, or it may always look like that. I would say we see that a lot with the gluteal muscles have a huge tendon that attaches to the side of the hip. And we see a lot of tendinosis with that, but it doesn't mean you're on the verge of tearing, going to need surgery, et cetera, et cetera. It's a little different with the rotator cuff, because that's something where if you have partial tearing of it, depending on the extent of the rotator cuff tearing, we know that those can progress and may potentially need surgery down the road, which is why the preventative treatment is so important. And sometimes we may monitor those a little more closely in terms of maybe MRIs, periodically, versus with the gluteal tendons, you may not do that.
That's great. Thank you. One more question just came in. And has any connection been suggested between the vaccines and athletic activity and injury?
Not that I know of. I would say it's obviously the vaccines haven't been around long enough, I think, to be able to test that either.
Okay. And questions keep coming in. We'll take the one more question for you, and then we'll move over to Aaron. And then this is from Judy. After an ankle fracture and not playing tennis for many years, what exercises would you suggest to gradually get back to tennis and hopefully prevent injury?
Ankle fracture. Okay. Probably depends on the extent of the fractures and whether you needed surgery and whether the ligaments were involved and this and that. But I would say in general, because you are doing impact and a lot of lateral movements with tennis, you really want to work up gradually to that if you haven't been doing it for a while. So I would start off with, obviously making sure you have the ankle mobility and the strength and that sort of thing, but then building up the ability to stay on the court for a period of time. And so starting probably with something low impact like swimming or spinning, and then moving up to the elliptical, and then incorporating some sort of running into your workout, because you're going to be doing that sort of start and stop on the court. But I'm sure Aaron can speak more to that too.
That's great. Thank you. And I'm just starting into pickleball myself, so that might be a in-between step before tennis as well. So
yes,
it seems a little bit lower impact.
Yeah, or starting with doubles first instead of singles.
Or doubles, yes, yeah. Right. Very good. Thank you. Okay, Aaron, we'll take it over. Thanks again, Dr. Colvin.
Thank you, Dr. Colvin. That was really insightful. I think I had at least half a dozen of those injuries that you presented. So I'm here today to talk about how to stay pain-free and what we can do to avoid some of these injuries. So allow me to share my screen. What I'd like to do is take everybody through a quick assessment of what you could expect when you come into the clinic if you have an injury, and what we typically see that is very common to lead to these knee or shoulder or back injuries or calf or what have you. And more importantly, it's not what we find in the clinic, it's what we do with those findings, and what we might suggest as a treatment plan. Now the USTA put this together, so I can't take credit for it. There's a wealth of information online, which I will share on the chat here before we're done, and you can take a closer look at it. But after we kind of dive into some of the typical findings we see in the clinic, then I'm going to do some demonstrations on what we found to be the most common exercises that might help prevent some of these shoulder injuries or upper body injuries. So I'll give you two upper body exercises. I'll give you two lower body and two core. So you'll have half a dozen here that you can go to. Again, this is all being recorded, so don't worry if you miss any of it. And at the end, I'm going to show you a video that the USTA put forth that shows a really amazing dynamic warm-up, which we'll get into a little bit too, as opposed to some static stretches. These dynamic warm-ups are really good to prevent injury before practice or pregame. So let's jump into it here. When you come in, typically, if you're a tennis player, we'll have you answer some of these questions. Can you see my cursor here, Greg? Yeah, a lot of the questions, if you have, let's say, tennis elbow or wrist or shoulder injuries, we'll find out what kind of grip you're using on your racket. A lot of the most common grips here, the continental grip, which is really mostly for serves and volleys. Versus the semi-Western, which is more like Rafa with big topspin, and Eastern forehand, which is more like Roger, which provides a little bit more of an open face, but not too much for his topspin. We'll ask you if you have any what type of backhand you have, because that can tell a lot if you have a one-handed backhand or a two-handed backhand. Most people have a one-handed forehand. So, and then we'll figure out like which, how active of a player you are. How many times do you play per week, which should tell a story. How much of the time do you spend off the court training, so on and so forth, and do a little bit of a medical history to see what kinds of injuries you may have had in the past. So getting into some of the upper body assessments here, you can see one of the things we do is we'll give you a 1 pound weight, and we'll have you lift your arms up overhead. And you can see on the top row here, this fellow has good symmetry. On the bottom, not so much here. This woman, has what we call scapular dyskinesis. There's a asymmetry with her shoulder blades moving in conjunction with her humeral head, which is not ideal, which can lead to a lot of shoulder and elbow injuries. So this is where some scapular and stabilization and strengthening come into play. We'll test your external rotation strength, which often tells a story about how injured, if at all, the rotator cuff is. If you have weakness in your external rotators, that would imply that you have some damage to the rotator cuff, either a partial or full tear. Then we'll check your range of motion. There should be adequate external rotation as well as internal. A lot of right-hand dominant players, for example, have limited internal rotation, which can lead to problems, especially on the deceleration of overhead athletes. Moving down here to the lower body, we'll check a single leg stance. We see a lot of times the knee buckling there. You can see in picture C how what we call valgus, that would indicate some hip and glute weakness, which is causing that, which can lead to knee pain. We see that all the time. And that's what we'll get into, some of the core strengthening that will help that. We do a jump test. If the knees buckle, again, it indicates that there's an inadequate hip and core strength there, which we see all the time, not just in our young athletes, but across the spectrum here. We'll check the hip range of motion and the hip flexor range of motion there, which are shortened on pretty much everyone, not just tennis players, I find. Of course, hamstring flexibility is important, not only for preventing hamstring strains and calf strains, but overall hip and knee strength. Quad flexibility oftentimes is very tight. So again, like these are the assessments that you can expect to go through when you come into the clinic. And then of course the plank test, you can see how this woman here, that's good form. Oftentimes what we'll see is like low back lordosis, sagging, inability to maintain that plank. And these side planks are pretty tough. So that's not unusual. So yeah, so that's pretty much it for the assessment. Now, what I'd like to do is get into some exercises here, which I'm gonna pin my screen here for a minute so I can see myself as I perform these here. Okay, so the first one that I want to show you guys is just a regular seated row or a standing row to help with what we talked a lot about was your scapular stability and strength. If you do a row, then you want to make sure your shoulder blades are first squeezed together before you pull. A lot of times what we see is this rowing here. People use it as an arm workout, but what I'd like to see is first squeezing the shoulder blades, getting those rhomboids and middle traps and lower traps activated, then pull. This will put your shoulders in a better position so that you'll get less impingement, less tendonitis when you perform overhead activities. So all these I would recommend, to do a few sets of 10 or 12, let's say, to fatigue. Sometimes it could be 8 reps, sometimes 10, sometimes 12. You just want to do it till you feel a little bit of fatigue and then back off, okay? So that's one of 2 of the upper body strengthening exercises. Another one that I really like is the rotator cuff exercise. So this one, just using a simple TheraBand here, and we're tying it against a solid surface. Again, shoulders are pinched together. You're in neutral. And I like to keep tension on the band. So even when you come out here, don't let it drop all the way. Go back about halfway, work in mid-range, and do it to fatigue. So I'm working my left rotator cuff here. Notice how my elbow is at 90 degrees. My shoulder is down. Sometimes I'll put like a towel between the arm and the chest just to give a little bit of space there. That can help provide some relief. So that's, again, you do it to fatigue, rest, you do a couple, 2-3 sets of those. And then you want to also do the internal rotation, which on my right, you can see, instead of going out, I'm pulling in. Just like that. So if you have a TheraBand, that works just as well. Let me grab one here. You can just hold it in your hands here, create a little bit of tension in the band, and off you go. Don't allow it to drop in, because that's really cheating yourself. You want to kind of go hold. You can hold a couple seconds and repeat. Okay. So those are the 2 most important upper body strengthening exercises that we see in the clinic that will really help avoid injury and help with your rehab. For lower body, a lot of times people come in with weakness in their glutes and their core. Again, your core is there any muscle really from your chest to your thighs. So it's not just your abs, it's your hips, it's your glutes, it's your abductors. And so one of my favorite ones to do that will prevent some of that knee valgus that you saw in those pictures are these side steps. And I like to use a loop around my ankles and then and do some little side steps side to side. So let me demonstrate real quick. So what you want to do is you want to get into like a little bit of a, you see that okay? You want to get into a little bit of a squat here. I'll show you from the side. It looks like this. So you're in a little bit of a squat, and then you take side steps. Keeping tension on the band, just like you did for the upper body, just like for the rotator cuff. You want to take tiny steps, keeping tension on. You go left, you go back to the right, and you should be feeling it all in your hips and your glutes here. So you're in a semi-squat position, and you go left and right. I would do it like 10 times left, 10 times to the right, and then repeat that 2 to 4 sets. And you should get a really nice burn in your hips and glutes, which I think will serve you really well. So that's one of the 2 lower body ones. And then, of course, my second favorite is the squat. What you saw in the pictures is when people jump, where they bend their knee, they bend it like this, can lead to a lot of patellar tendonitis, knee injuries. So what I like to see people do on their own, see if they can do a proper squat. Keeping the knees behind the toes, sticking the butt out like a ski tuck position, and then coming up. So this view looks like this. On the side, my weight's through my heels. I can lift my toes and not allow knees to cross there. That's how I know it's proper form. You hold it 10 seconds, 9, 8, 7, 6, 5, 4, 3, 2, 1. You can do a little mini bounce, get a nice burn in the glutes. You should feel it in the quads, all over. Not many of us do dynamic warm-ups before we start our games, but you may have heard a lot of talk recently about the importance of dynamic warm-up and flexibility training, because it's received a lot of attention lately as opposed to static stretching, and conclusions have been drawn about this type of warm-up that directly apply to tennis. So what it does is effectively, it increases your core body temperature, allowing the muscles to work more efficiently, gets the heart and lungs pumping, stretches the muscles actively, preparing them for forces that you experience during play, and ingrains proper movement patterns, coordinating that needed for tennis. And it wakes up your nervous system and gets the brain talking with the muscles. So I like to do these not even just before tennis, but like before a physical therapy treatment session, let's say. We'll incorporate some of these. So I want to take you through this real quick, and then we can go through it in a little bit more detail. Let's see here. So as opposed to just standing and bringing your knee to chest, she's walking, she's marching, she's lunging. Now this would require us to get to the court a good 15, 20 minutes in advance of play, which I think is important too, to be prepared for your match, to be well hydrated. All these dynamic movements are crucial for what you're about to experience when there's so much unknown, where the ball's going to go, where you have to run to. A lot of lateral movements, some pivoting here. Some people call this the world's greatest stretch, which is it gets your hip flexors, it gets your rotators. I'd be interested to hear from Dr. Colvin after this video as to how many of the pros she sees doing these exercises on the practice courts or before games, because I think they're very common. This is the inchworm, one of my favorites. I think if you showed up at the court, you saw your opponent doing these, like you would just automatically concede because you know that they're prepared. See, these are some of the rows that we were doing earlier. This works all different heads of the trapezius, the upper trap, the middle trap, the lower trap, gets your shoulders loose. And there's the rotator cuff external rotation exercise we did earlier, crucial. So that's pretty much all I got. If you guys have any questions, I'm happy to answer them.
And then one question came through. What if you have pain with any of these exercises, Aaron? What should you do?
Stop. So you never want to work through the pain. There should be, there's a difference between good pain and not so good pain. Good pain is fatigue, where you feel like like a little achy, a little sore, maybe the next day from working out. That's all good. Any sharp or pain or tingling or something that does like reproduces your symptoms that you've had for a while is no good. So you want to modify the exercises or just stop completely.
Now, what are the 4 or 5 most important dynamic stretches of those, would you say?
So I really like the inchworm, right? Where you stand, you walk out on your hands and you walk up. That gets your calves and your hamstrings. I really like the world's greatest stretch, where you're in that hip flexor stretch and you're twisting. For the upper body, I like some of the overhead internal external rotation exercises. It's hard to point to just 5 of them, Greg, because they're all good. But I know that not everyone has time to do them all. So for instance, if you have like a propensity for calf strains, then you're gonna have to throw in a downward dog or a calf stretch. And so that's where some of the pre-game or pre-practice stretches come into play. But also, it's not just about what you do, 5 or 10 minutes before, but it's about the cross training you do leading up to it. So I'm a big fan of yoga. I'm a big fan of foam rollers, massage, and I think Dr. Colvin can speak to that. I'm curious to hear which of the athletes that you work with do these dynamic warm-ups, and if they participate in other cross-training activities like yoga, like massage or acupuncture, or how common is a foam roller in the exercise room?
Well, I would say in terms of the dynamic warm-up, I would say that's pretty much universal, that everyone's doing that. And to speak about like massage therapy, when we travel with the Fed Cup team or the Davis Cup team, there's not a lot of support. It's the essential team that's needed, and one of them is a massage therapist. So that's how seriously it's taken. And then there's a physical therapist that travels with us as well. So there's someone that is there helping with the I think the foam rolling they can do themselves, but the recovery after playing, I would say, is critical too.
Great, thank you. Another question: can squats and lunges be done safely if one has patellofemoral arthritis?
Yeah, absolutely. You want to be careful. You want to modify it. If you have pain at all, like I said, during these squats or lunges, chances are that your form might be off a little bit. Your weight distribution might be off a little bit, especially with osteoarthritis, patellofemoral pain. The knee should never really cross the toe for squats or lunges. If that's the case, that could likely lead to anterior knee pain. So really, if you're struggling with that, you should have the guidance of a experienced trainer or PT that can help walk you through these exercises properly. But yes, I'm a proponent of these closed chain exercises, even for minimal or moderate osteoarthritis. I think it could really be helpful.
Thank you. I'd just like to add one comment too, as a physical therapist, just what we've seen in this past year, so many of us working from home and in makeshift workstations and on laptops, on kitchen tables and whatnot. We're much more in a hunched over position. And if you think, because now the weather's getting really great outside, you go out and just jump on that tennis court. That's great for Dr. Colvin's business. That's great for our business, because the injuries might happen if you don't do all those dynamic warm-ups. So I think it's just all of these exercises are very, very important for all of you to do, especially now, because we're just going from this position all day long on a laptop to all of a sudden these big reaches, your body's just not ready for it. So I encourage you to really look at the chat where those videos came from, and the USTA is a great resource for those.
I had a
Yes.
question come in earlier this week about tennis elbow and how to treat it. This is called a flex bar. And what it does is it helps it helps with your tennis elbow, because it helps with eccentric strengthening, which Dr. Colvin alluded to earlier. So I'm just going to demonstrate real quick how to use that. And again, this is more for, or not an acute stage, more like more chronic or subacute. If I have tennis elbow on my right side, what I want to do is I want to hold it palm facing me, turn it in a little bit, my wrist, and then I'm going to straighten out the bar, and I'm going to twist it like a towel this way. Once I do that, then I'm going to slowly let it go down, so I feel the stretch along that area that hurts. And then the little twist I like to add is this way. It gets some overpronation to really get those wrist extensors. So again, with my right tennis elbow, I hold palm facing me. I wring it like a towel this way. I let the bar release, and then I'll do a little twist at the end. So I hope that helps.
That's great, Aaron. Where can we get one of those flex bars?
Amazon.
All right, very good. Yeah, I think they're about $10 to $15 or so.
Yeah. And they come in different colors. Like red is like, I think the moderate size. So yellow is light, green is a little thicker. Red's a good place to start.
Yeah, that's great. Sounds like we're perfect timing there. One more came in. All right, yeah, someone just commenting that a great session, longtime client and believer in H&D, and Ginny gave her a new neck. So she wanted to thank us. So thank you for coming, Sandy, and joining us tonight. If there's no other questions, then we'll call it a night. Again, I thank you all for coming and spending a Thursday night with us. The weather's getting nice, so be careful and be safe out there. And special thanks to you, Aaron, and Dr. Colvin, for putting these presentations together and spending time with our H&D community. And let's all stay safe and have a great tennis season. All right. Bye-bye, everybody.
Thanks, Greg.
Night.